following intravenous cannula insertion. So first we'll move on to one of the clinical scenarios, and we'll discuss about the answers later in my slides, and also we'll discuss about some MCQs and SBA questions that may appear in the FRC exam. So this is about a 12-year-old girl who is admitted following a road traffic accident with an open book pelvic fracture, perineal injuries, and right-sided acute limb ischemia. After initial resuscitation, she is planned to undergo external fixation of the pelvis, fasciotomy of the limb, and emergency laparotomy and a defunctioning colostomy. She was transferred initially from resuscitation room to the operation theatre, and she was on a noradrenaline infusion via a peripheral cannula until the central venous access is obtained at theatre. And intraoperatively, there was blistering and skin peeling and edema of the same limb, which was noticed later. So the first question, define extravasation, how to explain the mechanism of tissue injury during noradrenaline extravasation. List 4 patient-related factors of this child that predisposed her to extravasation injury. Outline your immediate management in a structured approach. What are the specific pharmacological antidotes available for noradrenaline extravasation, and describe their mechanism of action. What measures should have been taken to prevent this complication in this child? So we'll try to find these answers in my presentation. And moving on to the presentation, this is my reference. What do you mean by extravasation? It is the inadvertent administration or leakage of the blood, lymph, or other fluid, including the drugs that we give, into the subcutaneous or subdermal tissues, instead of the intended vascular or lymphatic pathways. Reported incidence is between 0.1 to 6.5%, and the potential outcome can be catastrophic if it is undetected and leading to tissue injury. These are the risk factors. It can be patient-related, vein selection related, or provision of drugs. What are the patient-related risk factors? Increased skin or vein fragility that can be seen in extremes of age, elderly population, and corticosteroid use that can increase the vein fragility, chemotherapy that can cause difficult cannulation, and also IV drug use. Altered pain perception that is seen with the diabetes mellitus, peripheral vascular disease, and in stroke patients who lose the sensation of the apparent limb. And also impaired venous return in conditions like SVC obstruction and venous insufficiency. Especially communication impediment, as in our patient who was anesthetized, cannot complain of pain and sedated, unconscious, sometimes confused patients, and patients with language barriers. So they can't complain themselves. So we might lose the sight of clinical features, and this may go undetected. What are the risk factors of vein selection? If we insert a cannula distal to prior venipuncture site with extravasation, that must have caused extravasation of the drug. And periarticular areas like foot, ankle, antecubital fossa, easy to get extravasation. And sites of prior radiation, surgery, or lymphedema with fragile veins. Drug provision. When we use non-visible or inadequately secured insertion site, as in this patient who was in the clinical scenario, we usually drape the area, so we can't see the cannula site. So sometimes when we see the cannula site, already damage must have happened. That is one of the risk factors. So we need to examine these areas and examine actively for features of extravasation regularly, especially in anesthetized patients. When there's untrained or inexperienced personnel, sometimes features of extravasation may go unnoticed. If we use power injectors without pressure limiting alarms, as in ionized radiation insertion, so we won't detect the extravasation, and there's high pressure, so it will increase the risk of extravasation. And if we use butterfly needles like steel winged infusions, also in prolonged infusions or high infusion rates. So these are the risk factors. What are the signs and symptoms of extravasation? Usually we can detect signs and symptoms, most probably the symptoms, in conscious patients. Signs we need to actively look for, especially in anesthetized patients. So local appearance, there can be swelling mainly, erythema, blanching due to the inflammation, and purpura, blisters, and weeping, and if it is very severe, necrosis. So what are the sensory features? Patient can complain of tingling, burning sensation, tenderness, and absurd backflow of the blood. And infusion, there may be a resistance to the infusion or the syringe plunger, and infusion may not flow freely or has already stopped, and there can be leaking around the site. Severe consequences are it can cause tissue, tendon, and nerve damage, and also long-term sequelae can be complex regional pain syndrome, and functional and sensory impairment, loss of limb and tissue, which can be detrimental. So early injury recognition is very critical to delay the increased likelihood of irreversible tissue injury. We can classify the drugs according to the risk of injury. There are mainly 3 drugs: the vesicants, irritants, and neutrals. Vesicants are high-risk agents that have corrosive properties and potential for severe tissue destruction. They can be either hyperosmolar agents, vasoactive agents, and acidic or alkaline agents. So in this slide, I have highlighted in red color the agents that should be given warm compression as a treatment, and the blue color highlighted agents are the agents that should be given cold compression as a treatment. So in hyposmolar agents, examples are calcium chloride or gluconate, contrast media, glucose more than 10%. We should not give glucose more than 10% in peripheral IV cannula because of this hyperosmotic nature. And also parenteral nutrition. These agents should be given warm compression as a treatment. And other hyperosmolar contents like magnesium sulfate, mannitol more than 5%, methylene blue, sodium bicarbonate, sodium chloride more than 1.8%, and sodium valproate. They are again hyperosmolar agents, but we can use the cold compression as a treatment. I will discuss about these in my management strategies. What are the vasoactive agents? Most of them should be given warm compression apart from digoxin. So the vasoactive agents like adrenaline, noradrenaline, dopamine, dobutamine, vasopressin, phenylephrine, esmolol, all are vesicants. And acidic and alkaline agents are amiodarone, phenytoin, thiopentol. Most of the drugs that we used in anesthetized patients can be acidic or alkaline in nature. And what are the less irritant, low-risk irritant agents? Other drugs like antibiotics, ceftriaxone, cefuroxime, ciprofloxacin, amoxicillin, erythromycin, and anesthetic agents like fentanyl, etomidate, lignocaine. Those things are low-risk irritants. And I have highlighted again here, so you can go through this slide and see what are the drugs that should be given cold compression and what are the drugs that should be given warm compression. And very low risk agents, which are the neutral agents, are sodium chloride, Hartmann solution, and glucose less than 10%. They can cause swelling or discomfort but less tissue injury. How do we manage when we notice extravasation? Should stop infusion or IV bolus immediately and disconnect the drip line. If the patient is conscious and rational, we can explain then and there. And if it is an anesthetized patient, we can explain once appropriate. Aspirate as much as extravasated drug to the cannula and then remove it. And we have to mark the extravasation site with the indelible paint or photography, and to see whether these markings or whether the extravasation area is progressing over the time. There is a score called Milliam Assessment Grading Score. According to this score, we can assess the severity. I will discuss about this as well. And elevate the limb, apply cool or warm compression according to the drug. Initially about 15 to 20 minutes and then 4 hourly for 24 to 48 hours. We may have to refer high-risk patient to plastic surgical department and document and report the critical incident. This is the Milliam extravasation score. There are 4 gradings. All 4 gradings show the pain at infusion site. In grade 1, there's no swelling And in grade 2, some swelling is there. In grade 3, marked swelling is there. And in grade 4, again marked swelling is there. Capillary refilling time is normal up to grade 3, but it is reduced in grade 4. And pulses again are normal up to grade 4. If it is decreased or absent, it is grade 4. And there's no skin blanching in grade 1 and grade 2, and skin blanching will be there in grade 3 and grade 4. Skin is intact up to grade 2 and 3, and there's skin blistering and skin background in grade 4. These are the high risk criteria. So what are the high risk criteria? Vesicant drug extravasation. That means hyperosmolar, vasoconstrictor, alkaline or acidic drug, any volume is high risk. If it is an irritant drug, more than 5 ml of extravasation, that means moderate to large volume, is high risk. Grade 3 or 4 severity with any agent. High volume, more than 50 ml of any agent or smaller volume in young children is considered high risk. And if there is suspicion of compartment syndrome, again a high risk patient. We'll first look at the low risk management. We can do the conservative management by the usual team. If the patient is in care, we can monitor 4 hourly up to 72 hours. If it is outpatient or daycare surgery, minimum 4-hour observation before discharge. We have to discharge with clear instructions in these patients, written if there is severe progressive pain, paresthesia, reduced range of movements, new blistering or ulceration, and should give analgesia, non-constrictive dressings, limb elevation, and thermal therapy. So only 11 to 21% of extravasation eventually need surgical intervention. Most of them can be managed with this conservative treatment. So I discussed about the cool compression and warm compression, the drugs that should be given cool compression and warm compression. You can refer to that slide again. So the cool compression is used for non-vasoactive vesicants and non-irritants. The idea is we are trying to localize and neutralize the agent and limit the dispersion and to adjacent tissue, causing adjacent tissue damage. We can use cold compression initially 15 to 20 minutes and then 4 hourly for 24 to 48 hours. What do you mean by warm compression? It is used for irritants and vasoactive agents. We can't make the vessels constrict and localize them. So we are going to vasodilate and dilute them and disperse. So dispersion will decrease the local drug accumulation and local tissue destruction. As in cold compression, the same frequency of treatment can be used. And we have to keep in mind, incorrect temperature application can exacerbate the tissue injury. So always confirmed correct type of drug classes. There are specific antidotes. They are subcutaneous hyaluronidase and some other agents for vasoconstrictor extravasation. So what does subcutaneous hyaluronidase does? It is used for non-vasoactive agents. So it enzymatically increases the tissue permeability to facilitate the diffusion and systemic absorption. And the vasodilatory agents like topical GTN, subcutaneous phentolamine, and terbutaline will reduce tissue ischemia and necrotic injury. There are specialized surgical interventions. We can use them according to the volume of extravasation. Usually it is required in high-risk patients within 4 to 6 hours of extravasation. If the volume is low, we can use liposuction or modified gold flush out technique. That means we are creating multiple incisions across the area and sequentially flush saline through one end and disperse the noxious agent through the other end to encourage the egression of the irrigation fluid and extravasation. If it is a volume more than 50 ml without compartment syndrome, we can use another surgical technique, that is the squeeze technique. We can insert multiple punctures near the catheter inserted site and then manually squeeze the distended area to milk the extravasate towards the puncture point and promote efflux of the extravasate. If it is a large volume with compartment syndrome, we have to go for the fasciotomy to save the limb. Other measures are excision of debridement of wound and rarely amputation and reconstruction. So what are the take-home messages? Extravasation can occur 0.1 to 6.5% of IV medication, and vesicant drugs can cause catastrophic injury. Early recognition is critical as a constrictors. If it is high-risk patient, we have to refer to plastic surgery urgently. Documentation is very important and report the clinical incident. We'll discuss some of the MCQs regarding this topic. Regarding extravasation injury, this is a true and false question. Extravasation is defined as inadvertent leakage of fluid into subcutaneous or subdermal tissue. The reported incidence of extravasation with peripheral IV cannula is 10 to 20%. Vesicant drugs are capable of causing catastrophic tissue destruction. Noradrenaline is classified as a vasoactive vesicant agent. Neutral agents such as 0.19% sodium chloride can cause significant tissue necrosis. So you can go through the slides again if you want and find the answers. Try to find the answers, and I have given the answers in this slide below. So without looking at these answers first, just go through the guesses. So the next question is regarding risk factors. Peripheral vascular disease increases the risk due to altered pain perception. Antecubital fossa is safe and preferred site for long-term vasopressor infusions. Steel-finked butterfly needles increase the risk of extravasation injury. SVC obstruction in a patient is a patient-related risk factor due to impaired venous return. Extremes of age reduce the risk of extravasation due to increased venous compliance. Again, you can mark the answers and look at the correct answers that I have given below. Thermal therapy. Cool compress is used for non-vasoactive vesicants to localize and neutralize the injury. Warm compress is the correct treatment for noradrenaline extravasation. Cool compress is appropriate for glucose more than 10% extravasation. Thermal therapy should be applied for 15 to 20%, then repeated 2 hourly for 24 to 48 hours. Applying the wrong thermal therapy can exacerbate tissue injury. Regarding the Milliam grading scoring, grade 1 extravasation presents with pain at the infusion site but no swelling. Grade 2 has marked swelling with skin blanching. Grade 4 may include blistering and skin breakdown without reduced capillary refilling time. Grade 3 and 4 should always be referred to plastic surgical team. Normal capillary refill and normal pulses can be seen in grade 3 extravasation. Regarding the surgical management, window of opportunity for surgical intervention is 4 to 6 hours. 11 to 21% of all extravasation events require surgical intervention. Squeeze technique is used for low moderate volume extravasation. Fasciotomy is indicated when high volume extravasation is complicated by compartment syndrome. The modified gold flush out technique involves sequential saline flushing through multiple incisions. These are SBA questions. Again, I have given the answers, so you can go through the question and find the answer. This is another SBA question. Okay, I hope you got something to your mind using this presentation. So if you have any queries, you can comment and always ask if you want any further clarifications. Thank you, and we'll meet again with another video.